Alrighty, and so we're back and we're talking about how not to get sued, and now
Correct.
we kind of shared a little bit of general guidelines for standard of care and for things to do diagnostically, records and things like that to avoid getting sued, proper documentation and proper quality care and proper communication. And now you want to share a couple of cases with us.
Yes.
That have been lawsuits and
Yes.
what's entailed. So go ahead.
Okay, so our first case involves a 36-year-old Caucasian male who presented with pain on his lower left. When we looked at his medical history, he had aplastic anemia and he had a bone marrow transplant. He was taking some autoimmune medications. He had chronic sinusitis, a penicillin allergy. He was taking lisinopril and tacrolimus. In his record, he wrote that he uses chewing tobacco. In his past dental history, he attends once a year for hygiene. So this case starts out on March the 4th, 2008, where he had some pain in that lower left. It was determined that tooth number 19 required endodontic treatment, followed by a crown. After 1 year, everything seemed to be healing fine. Everything went well for approximately 8 years. In May of 2016, he presented to a new dentist, and again he complained of pain in the lower left. When the medical history was looked at, there was no evidence of an updated medical history at this point, so the dentist prescribed clindamycin for him to see if it would resolve. It did not, and towards the end of that year, in November 2016, he was referred to an endodontist for subsequent treatment. In November 2016, the endodontist saw the patient. He basically did a bunch of tests and determined that he had symptomatic apical periodontitis. He went ahead to perform apical surgery, and we can see from our records here, it was a very successful surgery. It was well done. In May 2017, which is approximately 6 months after the surgery was done, there's complete regeneration of the bone, which is the kind of result that you would expect to see from successful apical surgery. Now, the story doesn't end there, because in April in 2017, the patient came back and all of a sudden started complaining that they had pain in their ear. When the dentist took a look, there was some bony expansion in the area, and the tooth appeared to be in hyperocclusion. At that point in time, the dentist adjusted the bite and gave the dentist a Medrol dose pack and antibiotics. This situation went on for quite some period of time. The patient continued to experience symptoms, yet by looking at the radiograph and looking clinically at the tooth, everything appeared to be okay. The patient continued to have pain, and in June, the patient and his wife decided they're going to seek an outside opinion. They went to their general practitioner physician, who took a look in the oral cavity and immediately found that there was not a symmetry in the tongue, and the floor of the mouth was not symmetrical with the other side as well. He immediately sent the patient to an ear, nose, and throat specialist, who performed a biopsy, with the resulting diagnosis being squamous cell carcinoma. At the end of June, there was extensive surgery done. It removed the bulk of the tongue and the surrounding lymph nodes, and radiation therapy started soon after that. That patient was left with a permanent inability to speak or swallow, and was plagued with dry mouth and rampant caries. The result of that was an action brought against the dentist and the endodontist. So let's take a look at this and figure out what went wrong here. The medical history that was taken was very incomplete. There was no evidence of medications taking, a past bone marrow problem, and the fact that the patient was an active chewer of chewing tobacco. If you were to look at these things, we all know when you see that a patient is partaking in chewing tobacco, what are you thinking?
Yeah, oral cancer, obviously.
Yeah. And so if that were on the radar, if that was in the medical history, that might have led to a different conclusion in this case. Another question is communication. The patient is coming in and constantly informing the dentist that they still have pain. The dentist has the duty to make sure that he can account for the pain, and if he can't, oftentimes I see patients where I look at it, I can't figure out what the source of the pain is. I do all my testing, and then we have options. If that were to happen with you, what would you do?
If I have done all the testing and I can't find the results, then obviously it's time for a referral to somebody else.
Exactly.
Yeah.
Exactly. That's my point. The point is, you can't let someone continue to suffer believing that with pharmacology you can cure it. If it's outside your scope and you believe it's non-odontogenic or it's not going the way you think it's going, then at that point in time, it becomes time to involve another party.
And the endodontist here did a very good job with the surgery, obviously had very good results, but if pains like this persist, instead of, just kind of keeping the patient on a back burner, it's always a good idea to get a second opinion. Sending to a maxillofacial surgeon can give a little bit more thorough and a more medical kind of a background to these pains. Sometimes these pains could be neuropathic, could be neurological, and sometimes, as in this case, it could be devastatingly important. So Ian, in the future, for somebody like this, how can we avoid a problem that this endodontist went through, I guess?
Well, there's a few mistakes made in this case. The first one was the medical history. There was no very accurate medical history, so they did not know about the potential for an immune problem because they had depressed bone marrow. They did not know that the patient chews chewing tobacco. These are all risk factors for oral carcinoma. Now, that would have changed the direction of this case if they would have taken a valuable medical history. The second mistake here is not listening to the patient. The patient is telling you that they're in pain constantly. You have to do something, and it's not throwing pharmacology at the patient, it's finding out what the source of the problem is and addressing it. And if you're not comfortable addressing it, if you don't feel comfortable outside working on a tooth, then there's so many resources out there for you to refer to. There are oral pathologists, oral surgeons, general practitioner physicians, and ear, nose, and throat people. They're all there, and they'd welcome the opportunity to help you assess your patient.
I mean, the key is to distribute the responsibility. You have a certain amount of expertise in an area that you're working in, and there's areas that you don't know, and other people may not know as well, but that having that second opinion and the third opinion as needed is helpful. And you want to be in charge of making that referral because you want to have a network of people that you trust in their quality of work and that you can, work with as a team to get the best for the patient.
Right.
So this unfortunately ended up being working against the endodontist for that reason. And you know what, to be honest with you, it's kind of, I can understand that this is right, that the endodontist did not properly make the diagnosis, make the proper referral, but at the same time it's interesting and how, if you choose to chewing tobacco and having all of these issues, and then now all of a sudden the endodontist makes one mistake and they're responsible for all of the decisions that you made in terms of the...
Well, we have to understand that we are in fact oral physicians to some extent. So yes, we treat teeth, but the surrounding tissues can also be a problem, and if we're not comfortable, then we've got to send to someone who is comfortable.
No, you're absolutely right. So let's talk about one more case here then, so we can cap it off.
Right, so the last case we're going to take a peek at was a case which has a more favorable outcome for the dentist. It involves a patient who presented with an irreversible pulpitis on tooth number 18. The patient was given options. You could extract the tooth or you can do root canal, which would preserve the tooth, and they elected to preserve it. Now, the dentist noted that in this particular case, the inferior alveolar nerve was very, very close to the apices of the tooth. And he put it in his disclosure, in his consent form, and wrote it down in his chart. So he performed the root canal, did a very nice job. However, there was a bit of sealer which extruded, which can happen. We as endodontists know that this is normal sequelae in a lot of cases. It's not below the standard of care. It does happen. And then when the patient went home, they felt that the anesthetic lasted a bit longer, and 3 days later the patient called and experienced a bit of paresthesia and initiated a lawsuit.
3 days later they initiated a lawsuit?
Well, what happened was it went on for 3 days. She called a lawyer and immediately things went there. Now,
that's not normal, let's face the facts, right?
Yeah.
I mean, that's obviously a patient that is very litigious.
Of course.
You don't people after 3 days of anesthesia.
Definitely not, because we know that these things can take months to resolve. And generally speaking, most of them resolve within 6 months.
Right. I mean, you first try to get a medical resolution before you call your lawyer. You call your... But go ahead.
But anyhow, in this particular case, it did ultimately go to trial quite a bit later, and the court looked at it and said that certainly the procedure was performed within the standard of care, and the record keeping supported the fact that the dentist outlined the risk of this procedure. The patient knowingly entered that agreement to have the root canal performed, and unfortunately in this case it had a poor outcome with respect to the paresthesia, but the court said because of the documentation, because of the risks being involved, being outlined, there was no further action against the dentist.
Terrific. This is one, I guess, for the legal system kind of coming through.
Yes.
And understanding.
And certainly it shows you the value of keeping great records.
Yeah, exactly. I mean, that again goes back to the consent form, having a good consent form that explains all the risks and potential benefits. The issue, however, is that I've found my consent form is fairly condensed. I've found that if you want to include all of the risks, including the ones that are like, all the black swans, it just is daunting, and
people aren't going to read. They're not going to read it.
People aren't going to read it, right, in a sense either. And I would rather have them read the more common risks than not read anything at all, and then still be surprised even though they, signed the consent form.
And what I will often do is, if I'm dealing with this kind of situation where a tooth is close to the inferior alveolar, if I'm dealing with a tooth which is I know to be in the sinus, I will write a little note on that, an additional note, because we know over time what the risks are. If we have a situation where we know that it's a little bit higher risk in this particular case based on that individual thing, we'll customize that consent form for that patient and make it our point to make sure that they understand that that risk exists.
Yeah, I mean, that's probably more relevant to surgical cases, because in non-surgical cases, to be honest, I've done 28,000 cases. I haven't had a single one, even though they've been proximal. But I feel if you're just going to pay attention, you're not going to have an issue really with that. But in surgery, sometimes you're just so close, just pulling out on the flap that could cause some neuropraxis, which is temporary. I've never had any actually long-term paresthesia on surgery either. But I think that goes back to treatment planning as well, right? So part of actually the whole thing with the risk mitigation here, it's all about risk mitigation, right? Of
course.
And that risk mitigation goes into, from what you were talking about, from what I'm gathering, it goes all the way from the beginning of the diagnosis, record keeping, communicating with your patients adequately, making sure you're as clear and concise about the risk and benefits, and communicate as clearly as possible. But in some ways, you are also yourself trying to make sure that you manage cases in which you mitigate your own risk of potentially causing malpractice or iatrogenic events. It becomes win-win-win. I mean, obviously, the patients would be able to benefit in that scenario because they're not being exposed to high-risk procedures or being treated in a high-risk situation by someone who doesn't have the expertise, right? That's where referral comes in as an important factor in the whole thing. If you just kind of manage all of these factors, and hopefully if you don't run into litigious patients who don't call their lawyer after 3 days.
That's a problem too. But what you have to do is you have to get into the habit. This type of proofing your records, making sure that your work is done well, should become a regular habit. You shouldn't have to think about it. Every day when someone comes in, you look at the medical history, you review it, you sign it, the consent form, you review it with the patient. It doesn't take very long, and it goes a long, long way to helping avoid problems.
Yeah, I agree. It would be very important for all of us to kind of keep track of these potential, risk factors. And it is kind of like, it's no different than accounting, right? I mean, you can essentially deduct anything from your taxes until you get audited. And so that's what people do, is you have to be careful and imagine that you're going to be getting audited, whatever you want to do, constantly, so that you stay on top of things, do your record keeping properly, understand risk, your own capability, your own envelope of comfort, and then make sure you...
But always think of the record as you write it, but always think that someone is overseeing that, and how will they interpret that record. If you always have that in the back of your mind, you'll have no problem.
That's actually a really good... I think that's probably as a crux of an issue here, is that every time you are writing your records, imagine it's being read in a court of law.
Exactly.
Out loud.
And to lay people. Yeah. Will they be able to interpret that as you've presented the case well, and the patient made a very, very informed decision and understood exactly what was happening and why the consequences did happen? As long as you do that, I think you won't have a problem.
Yeah, I think that kind of sums it up as a whole then. Write well, write long enough that it is going to cover all of your bases, and at the same time write as if it's going to be read in a court of law.
Correct.
Alrighty, and that was great. Terrific. Thanks so much for doing this. I'm sure it was beneficial to some of the people out there who want to avoid getting sued.
I do.
I guess like all of us. Let's get it done.
Thank you.